With that, we are delighted to have Dr. Farchmin with us. Probably many of you, a familiar face. Was with, how long were you at Sawtooth Mountain Clinic?
A little over 7 years.
Little over 7 years as a provider there. He is a geriatrician. He is currently working at Essentia in Duluth as a
Geriatrician.
geriatrician guy. He's a geriatrician guy all the way around. Always has been, always will be, doggone it. So we're delighted to have you with us, and Dr. Farchmin.
Thank you, Christy. It's really nice to be back and see some faces I haven't seen in a long time. Julie had reached out about doing some conversations and about end of life and things like that. And so that's why I'm here. I just want to make it very clear that I'm hoping this will be a conversation, and not just a presentation. First and foremost, I'm looking at the little flyer here, and it's really kind of unnerving to see my name next to specialist. Because especially talking to this group, my specialty training was here. When I walked into my role down there, I suddenly became a specialist. But the other interesting dynamic is here I am presenting to my mentors who taught me how to do what I do. That's just to say that I'm not an expert about this. I don't know anybody can be an expert about this, but I will take that specialty title to have the opportunity that we can actually talk about this, because this is something we don't actually talk a lot about. So there's a lot of expertise in this room. There's a lot of expertise that I don't know about in this room. And so this is just opening it up. And so just kind of want to work through that. So just as introduction, I'm Kurt Farchmin. I am a family doc. And my first job out of residency was here doing the family document. And so was here for 7 years doing what we do up here. And then for a lot of reasons, family reasons, wanting to be closer to family, and we now have our own family, moved to Duluth. And I took the opportunity there for a lot of reasons, to switch into what they call elder care. Another name is the mobile care team. And basically what I do now is I don't have an office. I simply round at the nursing homes, assisted livings, and rehab centers. And so, which is actually a very interesting practice. It's called elder care. I had a 35-year-old die in the last year, and so it's not exactly that. It's the people who need that nursing home level of care that I do. And so, but as a side note, I was a little shocked. Here I am going to Duluth. I'm like, wow, I'm gonna have to figure out how to refer to specialists now, because up here you kind of have to deal with it. I mean, we use specialists and stuff.
Nothing. It's
But,
getting
um,
nothing. You're not. Sorry.
Oh, that's I was amazed how well my job up here prepared me for the really kind of remarkably limited resource setting of nursing homes. And it's about as hard to get somebody to a specialist visit there as it was up here. And so that's kind of a side. But yeah, so I am their family doc, basically, for people in long-term care. That's how I see my role down there. But most people in nursing home are nearing the end of life, and so I've done more of those conversations than I did up here. And so that's the opportunity to be here. But while we're on the topic of introductions, I just want to make sure I know who's in the room. I know if you're from the clinic, you can raise your hand. I know a lot of people from the clinic, so, right? Or were at the clinic. Hospital. Okay, yep, good. And kind of like health, I think, county.
And human services.
Okay, great. And that's a role that actually I really am interested in your guys' insight as we go through this. That's one that I don't know as much about. I know a lot about clinics and hospitals, but And Dale, I see from the faith community, welcome, thank you. Is there any other groups that I'm missing, either here or online?
Minnesota Aging Pathways Area Agency on Aging, we have represented. Anybody else online, feel free to put it in the chat or unmute yourself if you are a different group.
And of course, care partners.
Yeah, perfect. Yeah, that's great. So, as Julie and Christy and I were talking about kind of what we're doing, the idea was there's 4 talks. This is the first of them, and today is kind of, for me, a lot of just introductions, getting to know where you guys are at, and kind of actually some of this is setting a path forward for the next conversations. Because I want to be meeting needs or desires or things like that with this. So, but really kind of identifying the parties involved in these conversations. And then kind of from a very high level, talking about why this is hard and how some strategies that I've come up with in terms of making this a little easier and shifting that mindset as we go into this. Full disclosure, a lot of it's just stuff I know, but I'm helpful. So this is not evidence-based, this is a lot of this, but this is just things that I find helpful, which I don't know that you can have an evidence base, just talking to somebody who's done it before and hearing other people who've done this before and insights that they've gotten. So, and then the next talk is going to be spirituality, culture. That's going to be really important. You can't divorce that from this conversation, and so that's coming next. And then I'll be back, and then talking about being present in these conversations. My initial thought is to talk a little bit more about specific tools that may be available to help with them. I've got experience in my new role with some of them. And then the last one, talking about grief, and we'll be open about that. Those templates are largely blank right now, and I want to take a lot of, hopefully, a conversation here to talk about that. So,
End of life doulas, like that they're here too.
excellent, good. Yes, I know that they've been here. Are they online mostly? Okay, great.
As well as Grand Portage.
Yes, Grand Portage. I did see a lot of those names there. So this is good. And online, please feel free to jump in. And so that's kind of why I'm here. But now I'm going to make somebody talk, and I don't know why you are here. Here I am. I'm saying, here, I would like to talk with you about death. And I assume that you, in some way, are wanting to have that conversation. But I'm interested to know why people are here. And I don't know if anybody's willing to go first, but otherwise I'll pick up. Yeah.
So I'm always open to talk about death, but I'm always looking for new perspectives on different ways to talk about death and what especially community members are looking for from physicians and providers in terms of having that conversation.
Yes, and just so that everybody's aware, I mean, I'm sure a lot of people know your role, but what is your role?
So I took your job.
Yeah.
So,
Yeah. So, because that's another important thing is that, especially from my perspective, I'm coming at it from a doctor's perspective, which is different than a lot of others. And so I'm going to try to keep this broad enough that we can talk about the elements of these conversations, but I fully admit that I will wander into ways that I approach it that you may not be able to, and that's where I'd like to give some perspective. So, yeah, Caleb.
I see, so I'm a nurse practitioner, but then I meet each other. But I see how, I think talking about death in an abstract with patients or clients can be one thing, but the realities of how end of life happens is another thing, and reconciling those two worlds, I think, is a perpetual challenge.
Yeah.
Yeah.
So that's why I'm here, to
Yeah.
figure that
Yeah.
bridge.
Yes.
Figure that out.
Yeah.
Some tools.
Yep.
And I would just also add, maybe I'll quickly I'm just gonna quickly add, I think one of the beautiful things for having Kurt here come and speak with us is he does know Cook County. And we all know from working here that a big part of the challenge at end of life is we don't have hospice. We've got a lot of creative
compassionate people that live here, and we connect and we try to work together on what is it, that we can do and what is it we can't do, and how do we have those real conversations about what we have here and what we don't have here, and what that looks like in people making choices, honest choices. And that's another piece, is we could bring in somebody from anywhere, right? But it's wonderful to have Kurt here, who actually really knows this community and some of the challenges in having these conversations that are more than just, it's hard to talk about death. It's also hard to talk about death in Cook County when we want to be able to take care of them here. Sorry, you want to cry over here. And we can't sometimes, right? So that's part of the perspective that we want to share. And having the county folks here, just that recognizing how we're all serving and journeying with folks, right, during this season. So
Julie, that was about as good of a segue as we can on the next topic, but I want you to hold that thought because I want to hear what some other folks here from, yeah.
I'm Emily. I'm one of the care coordinators over at the clinic.
Yeah.
And I've only been there for 3 or 4 months.
Okay.
And I've been a nurse for almost 12 years, and 11 years and 8 months of that has been in the hospital. And so obviously the approach to death a lot of the times in the hospital, particularly in ICU surgery where I've worked, is a lot different. You're doing everything you can to prevent that from happening. So I'm a little out of my element with like some of the processes and just some of the different perspective on death and dying in the community. So
Great. Wow.
Actually, I'm sort of here as an outlier. I'm probably closer as I look around the room to the end of life. I am a retired physician, so I am no longer having those conversations about death and dying with other people. Folks are starting to have them with me, so that's kind of interesting. And I want to hear and all what people are saying, how they're approaching this, and also hopefully just support people that are doing this. And so that's why I'm here.
Dale, did you have your?
So 32 years ago, I showed up at Granbury, just graduated, had not yet graduated from seminary. My very first community incident was a double lightning strike in which a 12-year-old died and her mom survived. And I was providing, completely unprepared for the intensity of that. 32 years passed. 6 months ago, my wife died, and I was both her pastor and her husband. And that has caused me to realize how differently those conversations have changed over 3 decades, and how deficient some of them were before that. So I'm very interested in how those conversations will look like moving forward.
We have somebody online that said they're assisting clients in complete advance directives. So
Yes.
Yep.
Yep. Good.
Well, and I guess my biggest question is not just how to speak with the person who is dead, but is how to talk to family and caregivers, which is a different pathway. So more tools for helping the others, the surrounding community.
Right. Yeah. Who are we even having these conversations with? And are we legally allowed to? All of that. It's all in that same bucket. So from the county, just wondering what your perspective is, just because that's my own ignorance in terms of what you guys interact.
Well, we're both on the adult services and home and community services team, and some of our colleagues are online too. And so we do a pretty wide variety of things. So I provide care coordination for folks at the care center. So, working with adult protection, things like that. And Ariel works with folks trying to stay in their homes. Yes. So people trying to kind of stay in the county and get the services they need as they're aging, which is
That's a big
complicated conversation.
Yeah. Anybody else?
Yeah, we have some online. Friday now. Minnesota Aging Pathways accept referrals from hospitals, clinics, SNF to help connect services to families along with caregiver support. We talk about advanced planning and would love to give resources for families in order to have better conversations with families about end of life. That's from A. Olson. Rita Cole says, I am new to Grand Marais. I need to get the lay of the land, worked as a chaplain at St. Cloud Hospital, and briefly worked with hospice in Allen. We also have Maggie Anderson. We have an extraordinary member of the community, Kathy Reeves, who did a workshop on medical directives, but I still am full of questions. Fear of now having wishes granted in hospital care. So what happens when you go actually into the hospital?
Okay, okay.
I'm Jenny, I'm one of the clinic docs, and I have these conversations all the time, right? But it's still always amazing to me how much resistance there is to accepting change and aging. And then my new perspective is I have conversations with people in the clinic that mirror very closely the conversations I've had with my aging parents. And I'm much better at talking to my patients than my parents. I have passion for my patients than my mother.
To speak to that thing, my grandfather 2 weeks ago turned 100. About a year and 3 months prior, I had gone down to visit him, at which point something had happened, probably a cardiac event or something like that. And over that weekend, just prior to that, he transitioned to hospice. And I remember at one point, just fumbling, like here I am, I'm talking about death. And I remember telling my mom, like, I don't know what to do. I don't know how to do this for my own grandfather. And so that's just the reality of some of these conversations. And so, yeah, anything else online there? Okay, so,
I just wanted to also throw into the mix that there's also the cultural aspects that, some of that is I mean, we can't, we don't know what culture a person brings, or carries, but just by looking at them or caring for them in other ways for a time. And so that's something that I'm hoping to learn more about from the group, as well as from you, Kurt, is just different. Sometimes I think when we have these conversations and we feel this resistance, I feel like maybe I'm not, the language, the words, or frame, like the perspective a person brings, and their culture being part of that. And so just looking for other, ways to kind of work with that.
yeah. So the next topic, I think, or the next talk, I think, will be an important one for that one. So thank you guys. People actually raise their hand to talk this week. And again, a lot of what I'm coming from is the healthcare perspective, but I think, this idea that healthcare is here and we fix problems and we save people's lives. That's also, I think, in large part how society looks at this whole thing, as people, even if you're not particularly in the healthcare side of things, that's still the understanding. As you get sick, you go to the doctor. You're dying, you go there, so we don't. And so, but a lot of this is going to be just my own journey in terms of how to reframe this. But and I'll circle back on this later. But from the concept of aging, nearing the end of life, facing mortality, kind of one of the big picture viewpoints that I've come to is realizing that if we can't do this well, what are we doing at any point? And so, and kind of fleshing that out later. Julie was talking about the concept of hospice, and so I want to jump into that kind of first and foremost. But before I do that, has anybody here or online had experience working in a hospice group in recent past and willing to talk about that? No, it wouldn't be up here, hospice, but wondering if anybody is bringing that experience from somewhere else. Nothing online, nothing.
They are keeping it secret out there.
There's no family experience, a number of times, but not working for it.
Okay. would you be willing to talk a little bit about the family experience? Is that okay?
Sure,
And
I
if
know
not-
lots of people in here have family experience in hospice.
Yeah.
I mean, would anybody raise their hand if they had a family, they all really recently?
Yeah.
And online, I'm sure many people, am I okay standing here, Kelsey?
I got you.
Well, again, so my mom has gone through hospice. I've had some challenging experiences around the finances and when you can become hospice and how complicated sometimes the process of when you can actually add that to the covered. I won't get into that, but there's just an unfortunate complications of our systems getting in the way of actually a healthy, streamlined experience with hospice. Having said that, when hospice is in place, I lost a sister, journeyed with her, and my mom and my dad were the three closest to me that I journeyed with hospice. Really extraordinary people, having really holding our, I say that it's sort of the language of holding our confidence for us when we don't have it. I love that idea of some of our roles really is that we're helping hold the confidence that we've done this journey with others, or we've been with people. I think that we sort of hold confidence for folks when they're in the midst of this. And maybe if you've been the person holding confidence, to be the person needing someone else's confidence, you really see that, like you're talking about, Jenny, that distinction of being the person who is sort of the expert or able to be present versus the person that can't think straight because you're grieving and you're wondering if you're doing the right thing and making the right decisions. It's really different to be in that space when it's your own family. But I have had really positive, aside from sometimes getting the hospice lined up where it will get paid for. That's had a few stumbling blocks. But the experience itself has just been extraordinary and a really beautiful comfort. And again, without having hospice here, I think we are really creative on figuring out how to support as best we can. The healthcare part of it is what it is though, right? It's hard for neighbors to help administer medications that we need for pain, you know. But I don't know how much more I would say than that.
Thank you. For those, I mean, for those who have had personal family experiences, is that echoing more or less the experience that people have had?
I'm curious for just like, I think speaking kind of echoing what Emily had said, my experience has been in the hospital and I worked close, you know, in ICU when you're transitioning to death. And so we worked closely with our palliative care team. So I have a lot of experience with like helping patients pass comfortably and having those conversations with families. Like, unfortunately, working in the ICU, it happened a lot. And so now it's really hard in this setting, being in an outpatient setting and a rural setting where we don't even have that option for like, you know, administering medications and I don't know. So I'm very curious to know like how we can, what resources we have available because patients want to pass comfortably in their home and we don't have a hospice house or like,
So I wanted to start with that because I think that's kind of more or less when we're in Cook County and we're talking about conversation about death, that is the elephant in the room, which is that we don't have hospice. And spoiler alert, what I'm trying to do here is to fluff the egos of everyone in this room. So and I'll talk a little bit about that later, but my interactions, you talk about like hospice, the people, boots on the ground, the interactions with hospice they're amazing. It's an amazing service. However, the system integration of hospice can be complicated. And so just so that everybody's aware, when I talk to people about hospice, when I think about hospice, it is basically two things that are closely intertwined and you can't pull them apart. One is the philosophy of care, that we have somebody that is nearing the end of life. And either we are choosing to, but most often we are acknowledging that we are not able to stop this. And that we are nearing the end of life they have to put a number on it, so they say within 6 months. But it is this, how do we care for someone when we know we can't fix this problem? And is shifting in care to comfort care, sometimes what you hear, but how do we focus on, you know, in the here and now, in the days to weeks to months, how are we treating people's symptoms and things like that, and how are we pulling that apart? The second part, which is surprisingly intertwined with that, is it is a payment model. This is a Medicare benefit that is unlocked. This is part of being a member of our society, in that if you have been paying taxes, this is a benefit, and you get a certain dollar amount per day, regardless of what happens, and that takes care of your care. And so, but because of that, you know, and rightly so, before anybody just starts handing people money, they have to make sure that this qualifies and we're in the right spot and all of that. And then there's also limitations. You know, that if we're unlocking this pool of money, we're not paying for certain things. And that, I mean, there are just some of the realities of how that sort of thing needs to work. Resources are limited. But they're intricately tied to one another. And the nuts and bolts of how that gets played out and has played out makes for some interesting dynamics. You know, I had wonderful experiences with hospice through my training, came here, we didn't have it. And we talked in the doctor's meetings, like, oh man, how can we get it here? We've been trying. I think Sandy Stover had been really looking into that, and that was part of this. Care Partners was trying to kind of bridge some of those gaps. But then I transitioned back to Duluth, and I realized that actually in my training, some of the things that in hospice have actually changed. One thing that I was very surprised about, there are 5 hospice groups in Duluth Superior area. That surprised me. And that for-profit hospice is a thing. And that's not a bad thing, but it is a thing. And so it offers so much, but fundamentally, a lot of what it offers, because of that payment model, is it's more hands-on deck. It's more caring people who are specialized in treating for people nearing the end of life, that can come, that can administer meds, that can talk to family. There's music therapy, there's grief support, even after someone has died. There's all these beautiful services. However, Julie, if you're willing to talk about some of the experiences you had, once a loved one was on hospice, how much interaction did they have with their primary doctor and the people who had been caring for them up until that point?
Oh, yeah, I don't think we had much at all, really. You switch to your hospice team, yeah.
You don't.
Yeah.
And that's because of that payment model and just how expensive things are. The other thing is that right when I was going through medical school and was part of the hospice program, was a time where it transitioned away that to be a medical director of a hospice program, before that you needed to pass your boards and maintain your certification, but they changed it. So you actually had to go to a fellowship program, which you can imagine, did that increase or decrease the number of physicians in hospice programs?
Decrease.
It decreased it. And so largely the physician care is from a higher level administrative standpoint, confirming that people meet criteria and things like that. And then at the same time, we've got this, you know, if we're doing this money, we're paying for this. Anytime you go to the doctor's visit, and we all know that nowadays that costs a lot of money, that would be coming out of the Medicare pool and would reduce the amount of services for music therapy, nursing visits, all of that. And in order to do that, you don't really get that coverage from it. And so there's these really kind of interesting things that I came to here. And so because of all that, again, hospice is beautiful. But what I really want to say is this offer here is beautiful. and a whole different dynamic to do the experience of someone in hospice in another setting. Because like from a doctor standpoint, I got to be there through the whole thing. You know, we would have the conversations and it was, what's going on? What do you understand about your condition? I have to tell you, I can't fix this. And I have to tell you, I don't think anybody can fix this. What's important to you? How do we do this? Let's look at your meds. Do we need all these meds? Are any meds causing you problems? Are there other meds that normally we wouldn't use, but that might be right here? Okay. And then we do those. And then I see, how did that go? And we go back and forth and we talk to family and we guide people through this whole thing. Somewhere that has access to hospice, it's not so much these conversations. It's not, how do I approach this dying person and meet their needs? I mean, it is that, but largely the question is, can I refer you to hospice? And then hospice comes and has this conversation. And so that brings in a specialty group who knows how to do this, which is awesome. But at the same time, you lose some of that continuity. You lose some of that history. You lose some of that, yeah, I know your brother who knows this person and they do this and this impacts your care this way. And so it's not that one is better than the other, it's that they are different. And I just really, you know, I remember I was there. There's this inferiority complex about this whole thing, but I really want to say that there's a lot of beautiful things here that you can leverage that they can't do somewhere that has hospice. And so there's things that we don't have. We don't have those home services to get somebody in the home to help that would really help people stay at home longer. That would be so awesome up here. But at the same time, there are other things that we can do that they can't in a place like that. So, so what we're able to offer here is a continuity, a knowledge in the community and all of that. And you just take away all of that, like back and forth. Do we qualify? Do we not? We did. Now we don't. Now we're graduated. Now we got to transition care and get a whole nother team involved. It's not even part of the conversation here. And so we have a lot that we can offer patients in those ways. And it sounds weird because it's hard, but it is also something that people here as providers get to be a part of. I think that there's a huge meaning to be able to be part of this process of somebody dying. And while it's challenging and hard and can be sad and there is grief, it broadens our perspective as we take care of people. And so, yeah. So, you know, I think, so that's just kind of what I wanted to say about this. And certainly open to talking more about that, but I really want people to know if you have questions. I guess, does anybody have questions about that? But there's a lot that goes into hospice and things, but I was just really surprised at how mixed my experience was, especially since I'm in the nursing homes. And it's an interesting dynamic. You don't need a provider's order to refer to hospice. And so anybody can do it. A nurse on the floor, family members, they can refer to hospice. Hospice comes in and then they say, hey, they're interested in hospice. It's great. And then I sign off on the yes, I have to confirm that they would be appropriate, in my opinion, for hospice. I don't see that much in, even though I'm in that building, they're down the hall. And so sometimes I insert myself a little bit. Sometimes for my own needs, because I have a connection with that patient. Sometimes because I'm like, I have a perspective that I think could be helpful here, but officially, I'm not really involved. So keep that in mind.
There's a question in the chat.
Yeah.
Does the doctor give diagnosis here so that Cook County patients have access to equipment?
Equipment. Yeah. Well, so my experience with that is, well, first and foremost, I'm not the expert on equipment, but my experience with equipment is it's a lot easier to get certain equipment if you're on hospice.
Yeah.
A lot easier. Hospital beds, you know, anybody who's been a nurse in a hospital, like, you know, those oxygen trials you have to do and you have to write it down, and the providers have to say like, oh yeah, they had this percent oxygen at this time for this long and all of that to get them oxygen. Not a hospice, you can just say, hey, try this oxygen, do you feel better? Okay, yeah, there you go. You know, like, you know, throw away the oximeter. And so absolutely, I mean, we do a lot of that. And, you know, but the requirements and the level of documentation and stuff you need to get equipment is a much higher bar if you're not on hospice.
Yeah.
So,
And to get it paid for.
well, yeah, I mean, so that's the thing, that's the thing with everything. Anybody can do anything, but somebody's got to pay for it. And if, you know, and so, yeah, if you want insurance to pay for it, you've got a much higher bar. So, yeah, Kristen.
I have a question about, referring for like a palliative teleconsult. If this doesn't fit here in the conversation, we can save it for another time, but I wondered about like whether there's utility at all in, you know, I know Accenture does or has in the past done some teleconsults, and I don't know if, like, if that in any way, or if sort of the knowledge in the, you know, in the room on the ground here is always gonna be equivalent.
Yeah. And here, I just want to flush that out a little bit. When you say palliative consult, what specifically are you talking about?
Yeah, right, like a distinction, like, this isn't specific to hospice, but the palliative medicine service at Essentia that does a lot of overlap with
Yes,
end of life,
yes.
that,
Yes, so they are working on expanding. I mean, I'm speaking to Essentia, because I work for Essentia and in the elder care population, but they are expanding that to the outpatient area. It's typically been inpatient. I'm sure you probably worked with them sometime when you were there. And so just to clarify for people, nowadays the palliative medicine has become its own area that is distinct from hospice, although they interact a lot. But palliative is basically primarily a specialty about symptom management, difficult to treat symptoms, but it's not necessarily at the end of life. And that's usually how I see them seeing themselves. And so, but yes, they are expanding it. They're coming to some of the nursing homes and assisted livings in the area where if you've got really challenging symptoms, you can consult them. I can't speak for them, but I would suspect that they might be really excited if you had a challenging case and were wondering them, but that is a service that Essentia is developing.
There's a question in the chat too.
Yeah.
My dad is currently on hospice and his hospice company is from another county. Does Cook County not have hospice because no company is willing to cover the area?
Yeah, so in Jenny, you were probably part of some of these conversations, but my recollection in terms of the issues here is that in order to have a hospice service, I think at the time it was like you had to have 11 patients consistently.
Critical mass of patients for the bodies they'd have to have here to do the care.
Yeah, and so it's kind of the economics of it, which are just a reality. If you're going to have an RN, you know, a care aide, a music therapist, what's that? Meds available, you know, at any point, so that if there's a sudden decline in somebody and you're gonna bring somebody, you know, we need somebody there in the middle of the night. If you're gonna be able to pay for those services and not go bankrupt, you have to have a critical mass. And Cook County did not have a critical mass by themselves. And my understanding did reach out to other services, and they think there was something along the lines that needed to be financially solvent within their home.
It's a numbers game.
It's a numbers game. It's a numbers game.
Yeah.
And so, does that answer the question?
It's a complex answer. It's the answer that.
You had mentioned something about that, it was really hard to get, like, medical equipment paid for if, unless you went to hospice. So someone from the room can maybe tell me, we don't have hospice, so how does that work here? Like, do people just go without having medical equipment in end of life, or how does that work? Or do they just try to pay and go for it?
Well, you can get coverage for a lot of things through regular insurance.
Okay.
But you're gonna need a face-to-face doctor's visit. You're gonna need, to justify all of it. It may only be temporary. And then you've got to get the service to come up. I remember as I was leaving, getting an oxygen company to come up was like almost impossible to get oxygen tanks. And so like, especially through COVID, we were bringing concentrators because you didn't have to have a company coming up and refilling oxygen tanks and stuff. And so, you know, there's what you can get covered with insurance, which is its own high bar. And then there's, is there a company that's going to come up and do that?
I
Especially,
have people in the room that are really good at, it's my booster. It's a, that's what the news.
It sounds just like Cook County. Yeah, it can happen, but it's gonna be a lot complicated.
It's not a smooth
What
process.
fortunately we have is a lot of really dedicated people that are gonna try and make it happen.
Got it.
right, and the other thing I would say, working in a rehab environment where people are in there for a rehab in the nursing home and going home, we're in the same boat in terms of trying to get coverage for all the equipment, and it's a little easier because it's not as far for the medical supply companies to go through, but you guys do pretty good up here.
Can I speak into just, so we did have a situation where there was a patient who consulted with palliative at Essentia. I think they were in a long-term care facility actually as well in Duluth, decided they wanted to come home to pass with family. And, you know, called the clinic, of course, and I'm like, oh my God, we gotta get all the equipment, blah. And it actually was like, they did everything. And so the patient, family transported the patient, but all the equipment came with, like, and so the coordinator with the palliative care team did all of that. And so I felt like that was really helpful, having that team consult there in Duluth, and they set up all those supplies, hospital bed, all the things, like, it went pretty smoothly. And then, of course, one of our docs were aware, okay, and then I'm gonna write orders and get meds and send it to the pharmacy. And so we had I don't know, it was just I was really grateful for all the collaboration.
Yep. And to clarify, that was the palliative group, not hospice.
Yeah, it was a palliative group, and it was like the doctor actually called me
Yep.
from Essentia and like, what do you guys need? What resources do you have there? And I don't know, it was really, I can't remember the doctor's name, it's probably in one of my notes, but
Would you remember if I said it?
probably not.
Okay,
But,
okay. I would be really curious to
Yeah,
see who,
I
because
have it in the note.
there's on occasion, I've fielded questions from some of my partners in
Uh-huh.
public care, and some of them work in the hospital, and they're
Yeah.
like, hey, how does it work?
Yeah.
And
Oh,
so I'm curious if you were talking with palliative or if you're actually talking to a hospitalist colleague of mine. So,
Oh, okay.
but nonetheless,
It was so, like, I was so grateful and it was so smooth and like,
yeah. But
And-
your experience and Kristen, your question, that might be worth kind of connecting about a little bit, is to see if that palliative group, because I know they're excited, they're trying to expand. It's a very kind of new defined field, and so that may be an opportunity to connect with.
Yeah.
You know, I work for Essentia. I don't know Aspirus, but they may have someone. So.
And something like that only works with certain families.
Yep.
I mean,
Yep.
yeah, not every family can pull that off.
Yep.
Right, to bring somebody home.
So, kind of questions about hospice, because, you know, I've got other things to talk about, but that hospice question is actually a big one in how we interact up here.
And like doulas just want to say that they can help fill some of the gaps with not having hospice up here as well.
Yep. I want to transition a little bit in terms of like these conversations. So because to kind of come back to conversations and how do we talk about this? And I've got my beliefs, but I want to hear from you guys. Like, again, you've answered some of this for me already when I asked why were you, but from your guys' perspectives in your roles, why is it a safe assumption to say that it's hard to have these conversations? Okay, so because for some it may not be as hard. Our deaf doulas, you know, that's kind of the thing, and so. But nonetheless, there's a challenge to it. There's a reason that we have that. So just wondering if anybody's willing, and if nobody raises their hand, I got my whole list, but why is this hard?
I think it's hard anywhere, but I think it's especially hard here because I think there is a personality that lives in Cook County that's independent, that wants to preserve dignity, that wants to do things on their own terms. I'm generalizing, but I think we can name, plenty of people that we know in this community. And so I think that makes it extra challenging to kind of discuss end of life and extra support and.
Yep.
Yeah, I think that.
I guess as a nurse who, like I say, don't have a lot of experience having these type of conversations, I guess I never know like what's within my scope to talk to them about. Or like what's something that they really should like, because I'm always afraid of inserting myself in something that's not like, it's not appropriate for me to be discussing with them, I guess.
Yep.
I find in years of relationship with patients, it's often hard to know when I'm there. Where this is the conversation we need to be happening. It's like treat the condition, treat the condition, treat the condition. Just in my nursing home, I was yesterday, and the nurse at home said, well, we're on comfort cares here. I said, well, she's not dying. She's dying, yeah, I'm dying. We're all dying. But she died. When is that conversation? It's really, you get lost in the soup of all the things, and when is it really, okay, we stop all this and we do this, and when we not fighting disease anymore, or what are we living for, or what are the goals, so it's that messiness of knowing where you're at.
Yes.
And I worked in the hospital before coming to this job. I remember thinking like, my number one priority is end of life conversations with people, because when you're on the other side and you're in the hospital, like you don't want to be starting that conversation in the hospital during an acute illness. You want to have had the family and the patient have had some conversations before that moment. And so I remember thinking like, that's my mission. But like, I feel like I failed in achieving that. Like, where is the time? Where is that the priority in this mashup of like everyday issues and chronic care, chronic disease management? And then where does that fit? Like, if it's an annual checkup, there's not time. If it's some other time, there's not time. So we have to make the time. But like, what is the structure, the protocols or whatever that builds that into our care, rather than having it be something I'm supposed to individually remember to do for each particular patient?
That one's actually on my list, because as a provider who's talking with patients in visits in various forms, maybe in the hospital, maybe in the clinic, I came from the era too. I think we're in the same spot where it's like end of life conversations, like we're trained, like we got to do this, we got to get the word off. That is so great, but there's this other weird dynamic to it. Is you're at the annual visit and you're like, like it's in business. Okay, here I am. I'm at the computer. I'm looking through. Like, okay, we talk about your labs, your cholesterol. Okay. We should talk about that.
Your labs work good.
You can swear up and down your labs look fine, but like, it's like, Doc, what are you telling me, Doc? Or like, if you're in the hospital, like, hey, I know you're here for your knee replacement, but if your heart stopped, what should we do? Wait, is there a different surgeon I should talk to? Like that kind of a thing. And so it's this kind of like dynamic there. And so.
Well, I can imagine too, for instance, if you were in a non-medical and you're just trying to sort of broach the subject, are you like, so, anyone tell you you're dying lately? Or is this, like just, like how do you even gently ask the question that someone maybe is desperately trying to avoid?
And maybe just like part of that is separating the conversation. Like the conversation isn't just for when you're dying.
Yeah. And you can say that. You can say it. You can say it up and down, but as soon as you say, if your heart stops when you're off, you're like, wait, what do you mean?
Why would it stop?
Yeah.
I love talking about death. I can talk about it all day long. I'll take all your difficult patients to talk about it. But the hardest part for me is kind of like the reality check with patients. And, kind of like, you know, whether they envision this idealized version of death where they'll just overdose and that's it, or, you know, they think, well, I'll just have a heart attack or a stroke and that'll be it. And it's just like, okay, but what if you don't die and you just end up like severely disabled? Or what if, you know, you just end up vomiting up all the meds and that doesn't happen? Is, you know, it doesn't always work out. It's like, okay, but what's my timeline? It's like, dude, we doctors suck at prognosticating. Like, I don't know. That's why in hospice you're allowed to extend it by, you know, okay, another 6 months, another 6 months, another 6 months. Like, you know, it's that reality check. It's well, you know, what am I gonna, you know, how am I gonna die? What am I gonna die? Oh, it's just like, I don't know, you could throw a clot, you could, you know, forget to look both ways crossing traffic. I don't know.
Yep.
So.
Yeah, there's the perceptions, like, you know, people say, oh, I just want the big stroke, I want the big heart attack, I don't want to take my cholesterol. That's not how people die of strokes and heart attacks. They die of pneumonia, they die of aspiration, they die of, you know, these other things. And that's a reality that people wouldn't be able to know, but that's a conversation to have. And Kristen, kind of speak a little bit to what you're talking about. We're going to take a crack at some of the discussions up here. I got the opportunity, actually, Julie, I may not have mentioned it, but on the fourth talk, there's the just a community open to the whole public to have a conversation, and we're going to talk about advanced directives at that. And I'm going to give it a crack to talk to a whole room of patients at the same time, where it's not this individual like, hey, what are you saying to me, doc? Where we can just talk about some of that. So that's going to be out there. If you have people, you're like, hey, I don't have time, or that, you know, I'm not sure how to have this conversation. We're going to talk about some of that stuff.
And that's our October lunch and learn. So that's always the third one.
I just wanted to, you mentioned advanced directives, and I think that's a great lead in to what I was gonna say. And that is that, you know, if you are talking to your patients every year about, just asking them, are your advanced directives current? Do you wanna talk about, You know, and every time you broach that subject, it makes it easier, it makes the conversation easier for you, it makes the conversation easier for them. And when they come back and they do have some real concerns, then they can say, well, I know it's okay, it's safe to talk to my doctor about this because she brought it up, or he brought it up. And so there's a certain amount of deconditioning that has to happen on both sides.
Yep. And that's part of the motivation of getting it out there, which has been a great movement. Kristen, you were talking about it, just to have people talk more about it. But there's just kind of some of those kind of awkward nuances there. So I'm going to kind of get to my list just because I'm kind of aiming to a certain trajectory I want to get to. But it was touched on. One of it is, when am I going to die, doc? As a doctor, we don't. You know, like we're really bad at predicting. I think that's one of the few evidence base that we have out here is that predicting, you know, when somebody's needing hospice, is it 6 months or not? And you learn to be really careful about putting any sort of a time. You can say, I don't know, it may be months or whatever. Patients will say, they told me 2 months, and they live like they're going to die in 2 months, and when they don't, then they're like, my doctor's a quack, and they don't know what they're doing. And so, like, being able to talk about that is predicting is really, really a challenge. However, we can identify. You have a condition for which there is no cure. We can identify that, and kind of working through that pivot. And it's not saying so much this is your timeline, but this is your situation, and that reality is not going to go away whether you're here at the timeline and give it or not, because you have to give it time. They're going to pin it down. And you have to if you're going to, you know, certain things. So, one of the other challenges, and this is going to touch on the next talk, is people come with their own views of death a lot of different ways. That's a cultural, it's a spiritual, it's a religious, it's a social component. And the two kind of perspectives, and there's many, many more than this, but kind of examples of the two perspectives. There's Dylan Thomas poem, Do Not Go Gently Into That Good Night, I think is the name of the poem. But the last stanza is to his dying father, and he says, rage, rage against that dark night, or something along those lines. And there's this component of like, don't go, don't go into that light, fight it, there's that perspective. And then the other one that struck me as I knew we were going to have this, just as kind of a foil to that, has anybody read the Chronicles of Narnia? Okay, so it's kind of one of the later ones. It's the Silver Chair, and it's where some of these characters are meeting. Aslan, he's the lion, is kind of the Christ type in it, and they see somebody that they know. They're in one part of the world, now they're in this other part, and this guy had died, and now they're seeing him. So this is ghost. Wait, died. And the character says, "Well, yeah, he died. So did I. Most people have, and this." Like in the broad scope of eternity, most people have died. And like, yeah, what's the big deal? And so there's also this idea of this is not an end, this is a rite of passage. And so you got these two competing, like this is oblivion, this is a rite of passage. And as we have these conversations, we're going to encounter both of them. And I would argue we don't actually need to know exactly which one they're at. And sometimes it's helpful to not know the specifics. But we need to be prepared for both. We need to prepare for significant anxiety and then also almost a cavalier approach, like, no, and we're like, but I think this could help. Like, I think we should do this. And they're like, oh. But I would argue that sometimes we don't necessarily need to know exactly why, because most people are muddled. They may say, this is a rite of passage. Actually really scared. None of us have done this before. They're also really scared. And some people say, like, this is it, this is oblivion. And yet oblivion's actually a really hard concept. We can think about like, oh, what it'll be like for everybody when I'm not here, and what would I feel about that? Well, you're talking about what you would feel, but you're saying you don't exist. We actually have this inherent, we only know existing. And so there's this inherent thing that, to actually, oblivion's a more difficult concept. And so people kind of subconsciously carry an idea that they're going to be around even afterwards, in the way they talk about it. And so you have to be able to present that there's both this assumption that, it's kind of it's a transition and not necessarily an end, and then also be ready that people are really scared. And so just putting yourself in those shoes when you're talking to people is important. Can be a challenge. Who are we talking to? Can this patient even understand what we're talking about? Does this patient have a dementia? And if it is, who needs to be part of these conversations? What we'll talk about and really emphasize on the next one is the family meeting is the tool. Like when you're at a point when you got to do this, and the trick is when do you pull that trigger? But if you get to the point where you can have a family meeting, that is hugely, hugely beneficial. And those are the ones we're talking about. So just to kind of keep some of those things in mind, 25 minutes. Okay. So another pivot. And this is, so what is the leading cause of death in the United States?
Heart disease.
That's correct. I'm going to challenge and I'm going to say it's heart. This is a unifying human experience. There's not a whole lot in this world that every single person will experience, but this is one of them. And so, this concept of, this assumption that this is hard. This is hard. Like, to talk about it being easy, like, that seems silly, but is that really silly? Like, if this is really something that we're all going to experience, is it maybe a little more silly that nobody wants to talk about? And that's kind of part, like, I want to kind of flip some things a little bit on their head. And to talk, I had this concept I talked about with Julie and Christy when we were talking about this. I was trying to get it, and I'm sure it's out there, but you can envision in one of those medical documentaries, like, so we're in ER, this is ER, pit. I haven't seen it, but that's a new ER, whatever. And you get this idea, and you get this young person, and something terrible has happened, and they're coming in, they're running them on the gurney, they're going back to whatever they're going to do to fix them, and they see the doc, you can just, you know, doc, don't let me die. Don't let me die, doc. And the doc's like, I got you, man. Got you. You know, I mean, like, yeah, that's what happens, right? That's what it would look like in that show. And but it's actually kind of a silly thing. You know, like if you think about it, what's that guy saying? Don't let me die, doc. Is he saying, doc, make me immortal? Die. And then the doc says, okay, yeah, oh, that's weird. You know, and yet that the concept of that patient coming in, the doctor's going to save them. That's everybody's assumption. And there's that inherent assumption that that's our role in healthcare and in the system around, is that we keep people from dying. We save people. And that's also a patient's perception. I ran across this, I was looking up, you know, getting ready for this talk. It's actually a New England Journal of Medicine article. It's from the 90s. But for those who've looked at medical studies, they have the methods section where they talk about, you know, these are the nitty gritty. This is who we found and this is what we did. And the methods section was, we got all of us together and we watched every episode of ER from 1995. So I'm sure it was a real challenge for them, I'm sure. And it was what, ER, Chicago Hope, Rescue 911, and they looked at all the scenarios where somebody got CPR and stuff like that. And they were challenging this to what the actual reality was. First and foremost, they were all young people. Like they were like 75% were like under the age of 40 that were in the TV shows that happened. And then 75% of them made it fine in the short term, and 67 walked out of the hospital, no problem. Basically completely inverted from reality. And so that they're just kind of looking at that, but there's that assumption that we are here to save lives. And that's contrary to the fact that, like, at a certain point we can't. And so to kind of flesh that out a little bit, you know, we've got that, you know, like to go back to that initial gut feeling, like this young person coming in, oh, save me, doctor. Yeah, you know, yeah, that's what we want. That's what we want. We want a doctor who's going to save this patient. Well, we've all been in healthcare, ICU, stuff like that. Now make this a 95-year-old person with 3 active cancers who looks like a skeleton. Don't let me die, doc. The doctor's like, I can't. And we all know that we've been in healthcare. That's as obvious as the first one. The first one is, yeah, we're going to save them. The last one is, well, I can't. No matter what I do, no matter what anywhere does, Johns Hopkins, Mayo Clinic, nobody can. Okay, well, let's say they're 85 and they only have 2 active cancers. Maybe they're 75 and 1. Maybe they're 70 and they don't have cancer, but they're not really doing all that good. Maybe they're 60 and, oh, you know, that's where it's hard. You know, I mean, we can see it when it's obvious that we're at the end of life, and we can see we're at the beginning of life and we do everything we can to save them, but we work in the middle. We work in the middle. And so, and that's part of the reason it's hard, is we're not sure exactly where we are. But where I really, you know, in terms of approaching these conversations, I think the most important thing that I want to just kind of talk about and share that has been fundamentally helpful for me, our overarching goal, our fundamental job is not to save people. It's not to keep them from dying. It's to help them. It's to make their lives better. Now, we should all hope that our doctor, I mean, secondary goal is to keep you alive. But the ultimate goal is not that. The ultimate goal is that we are here to make people's lives better. That usually means making it longer, but not necessarily. And so keeping that fundamental goal in mind, realizing that usually we're looking through to keep them alive longer, but it gets us to that, once we get to the point where I actually can't, there's still a goal beyond that we've always been looking at. And that's the fundamental thing that I've found helpful for myself. And then realizing our own limitations. Most people attribute this quote to Voltaire. I attribute it to Dr. Simpson. The art of medicine is to amuse the patient while they cure themselves, which is the reality, just the reality that we're here, and largely a lot of our role is to help people through these processes. Now, Voltaire was very critical and cynical of the whole medical profession, but it does highlight the point that, some of our job is to just walk with people through this. And sometimes we overestimate what we can do. So Mylan and Jenny will laugh at this, but back in my day, when I was a medical student, one of the most pivotal things that happened pretty early on, third year medical student. You've been studying books for terrible hours, all, months on end. And now you're finally stepping into, you've seen some patients, you have to do your practice interviews and stuff. You're actually on the wards, you're in the hospital. You're no longer in the classroom. You're there. And my first rotation was in the hospital. And, here we're trying to remember all the stuff, and you're getting quizzed on everybody, and you're trying to know all the right numbers and what labs to look for. As an example, we still hand wrote history and physicals. I'm probably the last generation that can actually say that. So that's where this was. But so we're there, and here you're still at this level of your training where you still have most of your humanity. You're still coming at it from an outsider, and you're coming in and you're like, people are sick and they're suffering, and we're doing all these things and they're still sick. This guy in the psych ward is living in a cage. I've been there my whole month of rotation. Like, what? And I didn't have words to put it, but I was like, this doesn't fit. This doesn't sit well. And the most remarkable thing is I walked away from that rotation. Towards the end of a rotation, it was the only patient that I was unabashedly said, yeah, that felt right, was a homeless guy who came in for whatever symptom brought him in, and he had cancer everywhere. And to the point where they said, no matter what this is, we can't fix this. And the only order on his chart was 2 beers in. And you'd round on him and he'd be like, hey, how you feeling? And then he'd be like, hey, how you feeling? And I was like, how's the beer? And then you go, and that was the most positive image. That I felt that peaceful. And I'm like, wait, and I didn't even have the words or the framework to think about that, but it just that felt weird and wrong. That's not what my whole training is about. 2 rotations later, I had a hospice rotation. And this was at a time where physicians were more directly involved. So as a medical student learning how to be a physician, you have to be with physicians who actually got to go see patients in the hospice role. And I saw these devoted people who were there talking to people. And rather than like, hey, what's your cholesterol? What's your blood pressure? What's all this stuff? Like, all the stuff we normally do, it has absolutely only very indirect connection with how that person is feeling. And yet, and now here we're coming and you get to just say, hey, how are you feeling? I've got a lot of tools that can help you feel better. And I've got a lot of tools I can take away and you will feel better. And you realize that most of the treatments we have some level of cost. You have to take a pill, you have to identify you're sick, or you're actually having side effects from it, or they've been on chemo and you stop that and you're like, wow, I feel better. And I was like, wow. And suddenly I started to put it together with the homeless guy with the beer. And I came to that realization that concept of that ER scenario, that if that's my approach, and that's like basically the unstated thing that you're taught in medical school and sort of nursing and all work, I'm assuming it's similar, is that our job is to save lives. And it finally clicked. And it was, well, wait a minute. If that's my goal, I am going to fail every single one of my patients except the ones that live longer than me. And I was like, whoa, oh, okay. And then that made me realize that behind that goal of keeping somebody alive is a higher goal, which is that we're here to make somebody's life better. And that is what really shifted my whole focus, even when I'm seeing a newborn. When you think about that, then it can really change your whole outlook on how you do things. And so when you're talking to that patient, when I talk about residents that I work with now and try to give them some insight into their own world, like, you've got this is your grade A recommendation. This is, what we're supposed to recommend is the most effective. But when you actually get to know that patient, I'm like, yeah, really, I'm not feeling that one back. I don't like that. That's not the right one for me. This is why. And then you say, oh, yeah, okay. Rather than just trying to keep hitting that nail, you pivot and you realize that we're there to meet the patient where they are and to make their life better, and that doesn't necessarily mean longer. And so, one of the big reasons this conversation feels hard is it feels like a failure. If we even use that term, their health is failing. Like, they are failing. The patients feel like they are failing. We feel like we are failing. We did everything we could. I don't have anything more to offer you, is what it seems. But we don't have any more to offer you to keep you alive. But we have so much to continue to offer. It just looks different, except it's not really different. It should look different because everything we've been doing up until that point should be in that vein. And if you can keep that, if you can understand that, when you have this conversation, it's not an end, it's a pivot. And so that, the opportunity to come and talk about this is all the stuff I made up. But this is the stuff that I carry with me that, like, when you really kind of challenge like our general perceptions about dying and death and like what our role is. It's not so much that how do we approach end of life? How do we approach all of life? And if we can refocus that, it's just a sidestep, and it's not even a sidestep. You just keep stepping forward, and you can have these conversations. And then it's not so much as in hospice or as no, it's just, oh no, we're just gonna walk through this. We're gonna walk through this. And it's hard. It's still hard. I mean, death is hard. I think most worldviews would still see death as there's a badness, it's a hardness, it's a loss there. But it's inevitable. And so with that inevitability, how do we approach it? And if we just kind of rethink our role, that's what I found most helpful. Yeah, so it's not a failure, it's just a continuation, as long as you've kind of got that point. So, yeah.
I was just thinking about it, so I think it's helpful to know if a person is afraid of death or the process of dying.
Yep.
And we can be so helpful in that process of dying, which will ease them through to the death, but I think there's a distinction.
Right. And then also as you get, and especially depending on the situation, you're actually directly caring for their circle, and their family. And that becomes a lot of what it is.
Some point along the line, if not today, at some point, could you define for us a little more specifically what you mean by life? And I'm asking this particularly because the remainder of life being more pleasant is different than comparing with someone who's there.
Right.
And so if you could help us understand what you mean by that phrase like that, I can find helpful.
Where I take it, and this is not going to be a helpful definition because it's not a definition. It's that it's different for every situation. And that's the challenge, and that's the art. Whereas you've got that young person coming into the ER, like they're going to be willing to go through a lot of pain and the suffering so that they can walk out of there and hopefully have a family. That's different than somebody preparing for death. But part of the reason that I would argue that there is not a definition for what that better is that's different for everybody we interact with. From my perspective, they're a patient, but others it's a neighbor, it's, a member of the congregation or whatever, but that's going to be different for everybody. And so, and there is that transition, and where it can be really helpful to define that we are now no longer on the enjoyment of life track, and now we're out of how do we do with this dying thing, and enjoyment may not really be part of the conversation. I think that's maybe part of what you're talking about, like as we're getting towards the end of life, like enjoyment that may not be really a word that we can use in this patient situation, but meaningful, fulfilling, understanding this very hard reality. What's the best we can do in the meantime? And taking that lens of, rather than saying, okay, now we have to switch to this with, switch from how do we get the most out of life, how do we enjoy life, to now with this hard reality that we're dying and how do we deal with this, is to just take that step back and put the wet blanket on the entirety of life a little bit, to say, with the hard reality that we're all mortal, how do we live? And that's a much bigger question than our interaction in the healthcare field or the public health field. But I mean, this is my own personal world that I think, it feels a little bit like a wet blanket, but when you can actually realize that, and you realize that I am mortal and my time here is limited, I will live a little differently than if I'm not keeping that in mind. And I would argue I am living more fulfilled. I can find mission and things like that I might not if I'm pretending that I'm not mortal. And then as we're bringing that through that transition to end of life, it's like, okay, we're at this end of it. But I don't know if that speaks to you, to what your question was.
I think what I've seen is that better, and getting to the end of life, maybe when you ask people, what would make your life better? Well, I don't want to keep getting stuck by needles for all these tests, or I don't want to keep going out to the, for chemotherapy, or I don't want to have these symptoms, or I want to be pain-free. And then that's their better. And then that leads to, all right, let's take that away, and then we focus on the comfort.
Yes, and yes, and when we talk about this, those specific, I was kind of stuck on the high level thing, but yes, the specifics, that's part of the better. And the other thing that I would challenge too a little bit is, especially in the healthcare side, we kind of come at it with our goals in these conversations is that we stop all these treatments, that aren't really helping. We know they're not helping. We're going to make somebody DNR. That's what our goal is, because we know that these treatments can be harmful. We all know patients that they've been harmful to them. But the other thing that has really been helpful for me in these conversations is to wipe away those preconceived ideas and realize that if I go into this conversation and say, I'm this dying man who looks like a skeleton, says, yeah, I want CPR. I want everything. And we fleshed it out and they understand it. Okay. My job is to let you know what to expect. And they're like, yeah, I'm raging against this and I'm going to fight it. And that's what I want.
I think that really gets to value. What does the patient value? Do they value quality of life? Do they value quantity of life? And if they said they value quality, then what do you mean by that? What's valuable to you in that quality? And maybe I just want to live long enough to see my great grandson born, or maybe I just want to have conversations with my spouse, or What is it that makes life valuable? We struggle with that question throughout our entire lives, but it becomes very acute when we realize that there was a very limited time left.
Yep. Yep. So we've got just a few minutes left. Just want to have an opportunity. I've got 2 more talks that I'm going to be up here at. What is there any, and I've got my own ideas, but what would be helpful? Yeah, tell me some of
So
it.
many things. Just I guess ideas for future conversations, or not that we have to dig in now. I can see being in the role at the clinic setting and having these conversations with the pulse, like getting the pulse, figuring
Yeah.
out DNR, DNI. That living in between you had mentioned, like what's the in between? So it's, patients who, okay, I don't want CPR, but I want this, this, and this, and this. I still want, antibiotics, IV fluids, and like, where are we going to meet them for that, especially in our community, and communicating with the hospital if they need, like, they're hypovolemic, need some fluids, or, they have an infection, they need antibiotics. So like that living in between, I feel is hard. Another huge conversation is that activating the healthcare agent. You had mentioned like patients who get dementia, and we're having these conversations with them, and they don't even really know they're dying, and they're very like, why are you in here talking with me about this? And like very suspicious of like, who are you and why are you here? And I want to go home now. And then the spouse is also very cognitively declined and not sure if they can make those decisions. And so I feel like that's a huge gap that I would like to like be more informed about, and like collaborating with the providers, collaborating with the county on, we've activated the healthcare agent now. This is who's going to help make these decisions because they can't for themselves. So I would, if we have margin to talk about that, I think in one of the talks could be really helpful. And then for our patients who don't have the family support, we can't get a hold of family members. So who are we bringing in then? We have a cognitively declined patient without a healthcare directive and no family. And so then, what is okay, so now are we contacting the ombudsman, or like, who are we?
Somewhere over there.
Yeah. So I'm just kind of like, these are conversations just in the last few months where I've had these situations with patients. So anyway.
I'd like to see a good conversation too about, because we have folks here who are not just from the medical profession, but in other areas. And how can we work together? How can we figure out sort of who is the best person or a good person for what? And how can we really kind of continue to do what Cook County does, as we've said, but just sort of figure out how to get it done across a bunch of different organizations and. Yeah.
Yep. So kind of and that one would be almost much more facilitating this process and looking for chiming in from everybody, from the county, from the death doulas, like where are these gaps and how do we fill them here? Is that kind of what I'm hearing?
Or how do we even just, because we'll not, the minute we figure out what's going on and how we can connect with one another, something will change.
Yeah.
So how can we even just do the connection in the first place? How can we appropriately connect with one another in the midst of dying and death in a way that is helpful ultimately to the people we're serving?
And it might be that these conversations with Dr. Farchmin and some of this bringing things on, that at the end of these sessions, that we as a community say, let's meet and talk through this. That might be something, that is an outcome of this follow-up of this conversation with Dr. Farchmin and others, is to have some of that in our community now.
Yeah, Jenny and Alexis, this is me spitballing actively, right? I don't know if it's still happening, but we used to meet with school staff and stuff like that about coordinating for ADHD and kids who are struggling there. We've done that for old people.
We used to, not all together in a group like that.
You know, like we
Yeah.
brought
We would
together.
Send somebody to the elder
Care team.
care team, adult care team, and somebody from the adult care team. Care coordinators are like talking to, care partners, care coordinator. I mean, there's a lot of, not all players sitting at a table.
Right.
You
Well,
understand time constraints with that, but.
Yeah, but we used to do that for certain groups and that's.
Yep. So,
We haven't done any.
I get the sense that this is a great beginning, and
Yeah.
actually this entire series will be a great beginning. Or it has the opportunity for us to work together and find systems that will help us support, how we can do this together.
And I do see that we are at time, and I do want to honor time. Just a huge thank you, and this is the beginning of a conversation, which is awesome, and we thank you so much. What a wonderful facilitator you are of that conversation. We thank you for sharing. So, a care part, you have been loved by care partners now.
Thank you.
So much. Thank you, Dr. Bergstrom. Handing out the descriptions of the other sessions in this series. The next one is going to be on cultural perspectives and spirituality. If you do you have time after this to visit with folks if they want to
Yes.
visit a little bit with you? That's great. We thank you again for attending, and I hope that we will see you again next time.